it off where I want it or don't. Okay, so today we're going to do hand, wrist, and forearm, okay? We talked a little bit last week about SID, talked about that in class today, right? So when we're looking at the tube, you have your image receptor here, and then you have a little ruler on the back corner side here that will be your measurement, okay? So when we're coming down and we're measuring, we're bringing it down to the image receptor, not the tabletop, okay? So right there, I'm a little bit high, I'm at 41. So we come down to 40. Or what we can do too to help our patients feel a little more comfortable is we can raise the bed up a little. Up, not down. Where's the button?
The other one.
Other one. All right, so I'm gonna bring this up to where it's 40 there. Because for the forearm and stuff, it's better to have our patient elevated, okay? You guys can all kind of like shift this way too. So we'll start with hand and wrist and forearm. Let me go ahead and have somebody come be our victim, please. Oh, thanks, Raina. So have a seat there. So we know if we're at 40-inch SID, we can turn our collimator knobs to be at 12 top to bottom, 10 side to side, so that we're at least the size of our image receptor. And then we can close down from there, right? We know we can never be bigger than our image receptor. I'm gonna get in the drawer and get us a marker. Okay, so for our first picture, I'm gonna have you go ahead and put your hand flat there on the image receptor. Okay, for a hand, where do we center? Third MCP, right? That third knuckle. So remember, we're looking at our anatomy and envisioning the middle of the anatomy that we're looking at. So she kind of put her hand perfectly there. I'm gonna spread the fingers just a little bit. We don't want them to be like super spread where we're like tensing against the joints, just a little bit spread so we don't have soft tissue overlap, okay? I'm gonna go ahead and collimate side to side and top to bottom. We wanna make sure that we have light field coming a 1/2 inch to 1 inch past the middle fingertip, and then make sure that your thumb's in a little bit so we don't clip it, and we have light field all the way around, okay? So this is a PA hand. The next view for the hand we go to is the oblique. So it's a 45-degree oblique. So I always ask my patients to go from flat to halfway up. Okay, so roll your hand halfway up. Make sure that the thumb stays nice and flat and doesn't pop upward. Okay, so she did good there. And then I'm still centering at the third MCP. So I'm gonna move her the whole thing just a little bit. With tabletop work, we can move anything. We can move the actual tabletop, we can move our patient, we can move the tube, it doesn't matter. When we get into work that we're doing the actual bucky tray, then we have to be more careful about what we're moving because we have to keep our image receptor aligned, okay? But when we're doing tabletop stuff, this is fine. And then we don't really have to make any changes to our collimation or anything because her hand came up, but it stayed the same size. Bring the thumb in just a little bit, and there's our oblique hand, right? So PA, 45-degree oblique, and then lateral. So for the lateral, I'm gonna have her do a karate chop for me, and then we're gonna do that okay sign, right? So go ahead and turn your hand in an okay sign. We wanna bring the pinky out, because the goal is when we're PA, we're seeing each finger individually. So when we go to the lateral, we want to make sure we're seeing each finger individually. Okay, so that's why we fan them apart. So her fingers are fanned apart. Your thumb's off the tense looking. There we go. I'm centered here on the second MCP, right here on the top, right? And that is stacked in line with the second, third, fourth, and fifth. And then the biggest thing is making sure that her hand is rolled all the way up. We don't want her hand down like this. We want to roll up so that those metacarpals are stacked, okay? So she's rolled up there, my marker's still here in the corner, and then I have my shadows in the light field. That's the important part because we have OID that we can't do anything about between her thumb and the image receptor, so make sure you're not cutting off the shadow, okay? So that's my lateral. One other thing, do you see how her hand is kind of in? We want to make sure her wrist is straight, so I like that better. So making sure that the wrist and the hand are in alignment because we are including the distal radius and ulna in that image. So we want it to look as pretty as possible too, okay? So hand view, PA, 45-degree oblique, fan lateral, okay? A specialty view for the hand that won't be on practicum would be the extension lateral. So that's where my patient's just gonna straighten all her fingers together. This, and then we bring the thumb to the side just a little bit, and we center still on the second MCP. This is used for one, if a patient is super injured and unable to fan their fingers apart, or if we're looking for some type of foreign body, so metal, glass, rocks, something like that in the palm of the hand. We do it like this so that the palm's free of superimposition, okay? A pretty simple position. Occasionally we'll do this, it is not frequent. This is the one that you're going to do everywhere that you go as part of a routine for a hand, okay? Moving on to the wrist, we're still gonna use the 10x12 image receptor. So I'm gonna have my patient put her hand flat again, and then scoot your whole arm forward for me. Good, come a little more, so that we're centered on the, I'm gonna move this too. Okay. Now, I want you guys to note something. When her hand is flat like this, I can stick my finger underneath her wrist, okay? When it's resting on the table, I'm gonna take this off so I can show you. Our hand naturally has this like bridge where we can see underneath the wrist. So we have our patient scrunch their fingers up and it flattens that wrist down. Did you feel it go flatter from there? So when she brings her fingers, do it a little more. Now it's nice and flat and we're centering mid-carpal. So I'm gonna bring this toward me. Ooh, we're out of movement. Okay. Your collimation for a wrist, we want to make sure, again, we're centered mid-carpal, and then the distal portion of your light field is gonna be right at the MCPs, at the knuckles, and then however much of the forearm we see is plenty, okay? So it's about 2 inches. When we're talking measurements with your hands, this is about 1 inch, so then this is about 2 inches, all 4 fingers. So we have about 2 inches above the carpals and 2 inches below, okay? So then my left marker, we leave it open side to side enough to fit that marker in the light, but not in the shadow. If it's in the shadow, it's going to be in the anatomy, okay? So that's a PA wrist. Again, we're centered mid-carpal. I have my marker here in the light field and those fingers are squinched up just a little bit, okay? For the oblique, she's gonna straighten her fingers, which really I don't know that it matters if her fingers are straight, but it's just out of habit, straighten the fingers. And then now we're going to the same oblique position as the hand, rolling halfway up to that 45, okay? The difference here is where we center. So now instead of centering on the hand, we're centering on the wrist. So it's still mid-carpal. Still centering mid-carpal, and then my light field still is here at the MCPs up to the mid-forearm. Okay, with wrist, once you have everything set up for that initial image, you typically don't have to do much adjusting from there. It's typically for the PA wrist, and then you don't have to change your collimation or your anything like that. Centering maybe just a little bit. Okay, so oblique, and then lateral lastly, so all the way on the side like a karate chop. Now, I want everyone to get hold of yourself or your neighbor. My hand looks like it's lateral right here, right? If you put your fingers over your wrist, you roll out until you kind of feel those bones lay on top of each other. Do you feel that? So grab like this and go out. Do you feel where it happens? So if you're here, so everyone do it on your neighbor. So
do we start like a lateral position or do we just?
So like what you normally are gonna think is lateral, like right here, my hand looks lateral, but if I put my fingers here, I can feel that my radius is sitting this way. So when I roll out, you can feel where it kind of rolls on top. We'll play with that in a minute. Okay. So anyway, do that. You feel here, roll until your patient is good and lateral. We're still centered at the carpals, so basically here at the base of the thumb. Kind of, this is also called the snuff box. That's a good spot to center for the lateral. If you kind of push up everyone has this little dip right here, and that it's usually more pronounced on dudes. But center there, we have our left marker there, and that is my lateral wrist. Okay, so for the wrist, it's PA with the fingers squinched up, oblique, and then all the way on the side lateral. Okay, the specialty for wrist, if our patient will put her hand flat again, is that ulnar deviation. That's the one that you're going to see the most frequently, and that's going to be where her fingers come this way, typically till the thumb is like straight with the arm. Does that make sense?
Yeah.
So here, my thumb's sticking out, and when I ulnar deviate, it gets kind of in line. It's to see the scaphoid. So that being said, we can collimate down a whole bunch. So we're really just looking at that scaphoid. We want to make sure that it's the focus and center of attention. So collimate way down. Leave it up inside the side where we can see that left marker, but that's that ulnar deviation. Okay. Lastly, talking about forearm, I'm going to take my small image receptor. We're going to move to a big one. The biggest thing with the forearm is making sure that the humerus is flat. You have to get that humerus flat. So when you're working in the field, most of the machines are going to be mounted from the ceiling. So you're able to raise your table up higher to get your patient's arm up instead of them having to slouch down and get uncomfortable. But with this room, sorry, you're going to have to. So I want you to put your arm out with your palm up, because remember for forearm, it's AP. So if you need to scoot the stool back a little more to get your humerus flatter, yeah, you gotta get your shoulder in the same plane as the hand. And then we are going to center mid forearm. There's a couple ways to do this. Some people like to find like the elbow bend and the wrist and come together. My theory with it is as long as we're seeing this proximal portion of the palm of the hand and we're seeing above the elbow crease, we're fine. Because we need to see the entirety of the two joints above and below the long bone, okay? So she's like this. The biggest thing is making sure that her arm is flat. On some people, they tend to roll too far outward. So if that happens, then we're distorting the elbow joint. So you need to make sure that the hand is nice and flat and the elbow. So Raina does pretty good of getting in that position naturally. So that's our AP forearm, okay? Palm out and up, and then the lateral, she's going to make an L with her arm. Lateral L, okay? So bend, and we'll turn our image receptor to match. Good. And then again, you gotta get that shoulder all the way down. So you're gonna have to scoot that way, yep, but keep your wrist up. Come forward a little bit. So we want the elbow to be at a 90-degree bend, okay? We need that humerus all the way flat, and then the wrist and that lateral again, okay? So same centering, mid forearm. I'm going to come in a little bit, and then I'm just gonna change my collimation to be up and down with her anatomy versus across. Now the biggest thing people mess up on here is they tend to forget that we still need the back of the elbow. Our olecranon process of the ulna is all the way there, right? So you have to see all of that soft tissue on the posterior aspect. So we want to see left field behind, and then coming up again where it would be kind of mid palm. And my left marker, her shoulder's flat, wrist is good. That's your lateral forearm, okay? Forearms, it's just the two views because it's a long bone. So we do the AP and then 90 degrees difference to the lateral. No obliques. Obliques are when we're looking at joint containing things, okay? All right.